everyone, welcome back to the Dr. Sia channel. In the video here today, we're going to be responding to one of my viewers here on this channel who has requested for me to talk about ward settings and disorganized patients in ward settings and what factors are at play there that might make it not helpful. So let's get started. Now I'm just going to be spitballing here based on my own experience, all right? So if you're in a ward setting, if you work in a ward setting, I don't mean to hurt you or harm you in any way, but these are just some of my experiences that I've had around why it hasn't been helpful or what makes it not helpful. Not that it's not completely not helpful, but what does make it not helpful to treat disorganized patients in ward settings. Now, some of the factors that I've seen that make it unhelpful for people who have disorganized attachment in ward settings, one of the main ones is that a ward setting is completely different to a naturalistic setting. And that causes some complications. And of course, that's the same thing that's trying to help. So in one way, it's trying to help by going, okay, well, let's just remove the world. And for a moment, let's just take care of you, feed you, and let's just pretend for a moment that the world is just these walls. And however helpful that is, it also relates to the same issue that exists for people with disorganized attachments, which is that they never really actually regulate. So in the real world, they don't know a way to regulate within. And all they can do is to change their world, make people go away or make people disappear or disappear themselves and so on and so forth. So ward settings kind of contribute to that. They gives the disorganized patient a form of calm for a moment, where for the duration of their stay, they can pretend like the world in a way doesn't exist and this is the world. But there's not a lot of generalization that happens there. When they leave the ward, the world kicks back in again. When they leave those four walls, the world happens to them again. And unless there's been enough work done within the ward setting to ensure that the person can regulate, that they have some regulatory mechanisms, they go back to the world from the ward, and then boom, the world happens again. Because out there are men who are interested, there are women who are interested, there are people who believe in the disorganized patient, who are going to be kind and caring and nurturing towards the disorganized patient, and that is going to trigger their attachment trauma. Now, similarly, or indifferently, there might be people out there who might be aggressive and violent and abusive, and that's also going to trigger the disorganized patient's trauma. Now, so what do we do, right? What do we do about these ward settings? Well, often what happens, and in so many countries what happens is, we also force a disorganized person into a ward setting, right? Through involuntary treatment orders or whatever the acronym or whatever the word is in whatever country you are. Often patients are forced in a way to receive treatment. Now that again causes complications because there is no regulation within a forced treatment. You can't help a person regulate if they are forced to receive the treatment with you. And while within that context, there are things to do, there are things you can do to help a person's motivation. If that's not done, if the person doesn't realize why they need the treatment, if they at the end of the day don't want the treatment, then it's not going to work. So that's the second issue, is that in ward settings, many times, disorganized patients don't want treatment. They're just there to momentarily regulate or to get some other external benefit from it, or because they've been told that they have to. So in ward settings, what we need to do is we need to make sure that the treatment that the patient is receiving is generalizable to the real world, and that they actually work on something that they want to work on. Now, a final problem, one of the final big problems that I've seen in ward settings, which is a touchy subject, but I don't care. I'll go for the touchy subject and you tell me if I'm wrong. Oftentimes, people who are working in ward settings as opposed to in outpatient settings are the last people who should be working with people in ward settings. And what I mean by that is, often what happens is the people who are the most competent, the most capable, the most kind of, know the most about therapy and so on and so forth, often, I'm not saying every time. So if you're out there and you feel extremely competent right now, don't feel the urge to smash me. I don't mean you, I mean your colleagues or whatever. Let's just externalize it onto somebody else. What I'm talking about is often people who are working in ward settings are the ones who are the least trained to do so, who are the least trained to actually treat the severity that comes through ward settings. If you think about most of the world greats right now in therapy, most of them are not working in ward settings. Most of them are working in outpatient settings in their own clinics that they've established a reputation where people come and see them. And then what that means is that a lot of people who just graduate, who've done a year or two of work, end up working in these what do you call it? These collaborative teams together with other people in a ward. And often most people in those teams are not actually very highly trained. So this is an issue where, again, the same thing also happens with people who have severe problems, often have a caseworker or something that's working with them. The person who's the closest to them and works with them the most is the least trained person. So this is an issue, and I don't really have a solution for it other than to say that we have to make sure that we don't think that the team nature of wards, or the fact that there's so much security around or whatever, makes us complacent towards the extreme level of training that people would need in ward settings. I would think that if I'm out here and by average I'm seeing even 20% of the severity of patients that they see in ward settings, I think that would mean that they need more training, more support, that staff need more resources and more training resources to be better able at treating their patients, rather than us just kind of forcing the patient into some form of, I don't know, whatever makes the ward work. And often I've found that that's what happens, is that we force the patient into making it work for the ward, as opposed to making the ward work for the patient, if you will. So what are then some solutions I have here, just not to just complain and actually have something to contribute? Well, for the first one, for that first thing that is the issue, which is that there's not generalizable, one of the first things I can say, if you're working in a ward setting and your patients are extremely unwell and you're not catching projection one way or another, then you're probably missing out on one of the most common issues that your patients are experiencing. So what we need to do in ward settings is work a lot on projection. We have seen, and research has shown, that work on projection generalizes. Now, whether that's through cognitive behavioral therapy literature or through psychodynamic literature or whatever kind of therapeutic literature it might be through, working on projections or mind reading or so on and so forth, whatever they're going to call it, is extremely effective and extremely necessary. So if you're at a ward and you're seeing this and you tend to work with the team, start telling your colleagues about how important it is to work on projections with your patients. Secondly, it's to work on the patient's motivations towards getting better. And that's towards working on their own will, their own want, and what they want to get better in their lives. If you're not working on their wishes, their wants, their fantasies, their so on and so forth, their drives, then at the end of the day, it's a coercive experience for them, and it might be calming in that very moment there somehow, but they're going to leave with it with a lot of resentment within them. Now, finally, what do we do about this undertraining thing? Well, we need to make sure that people at wards, whether they are newly trained or whether they've been there for a long time, that there's one, resources available, two, a lot of continued professional development. And I don't just mean, continued professional development like random workshops. I mean specific workshops on how to work with these people. So one of the people that I know, for example, Dr. Stephen Arthey in Australia, he goes to these wards and he teaches them about how to work with these really severely fragile and hurt and disorganized individuals. But that doesn't happen everywhere, and doesn't happen at every hospital, and doesn't even happen at every institution within hospitals. So, or wards in any kind. So we need to make sure that these people are getting lots of support. The people who work there get lots of support, get lots and lots and lots and lots of training, and specifically in what they do. And we also need to make sure that they develop a psychotherapeutic relationship with the people in the wards, which is something that often doesn't happen. Often, to me, what happens at wards looks something between psychiatry and social work, and that's the end of that. And then you have a bunch of psychologists who end up doing social work, really, but not really being trained. Now, again, if you're a psychotherapist out there in a ward and you're doing great psychotherapy in a ward, good on you. But my experience says a lot of the psychotherapists in wards are disgruntled, they're upset, they're not actually getting to do real therapy with their patients. They're actually doing something that looks more like social work, and they're not trained in social work. So it's like, I think these are 3 ways that we could update our wards to help better for disorganized patients. I hope that this kind of resonates with you. I hope the person who wrote to me about this and wanted more on this that this resonates with you, that you get something out of this. Let me know what other problems you see in wards, and I'll see you again for the next video.